stenosis, steno-occlusive lesions, thrombus, and mural abnormalities like calcification, which can develop over years. Here in this image, we can well appreciate the full length of the RCA, that is a proximal and mid aneurysm. Here we can see a filling defect suggestive of thrombus, the LAD which is dilated with the branching of the LAD. Here we can see the RCA. If we do, this is the mid portion, which is fusiformly dilated, and here we can see this white thing, there's a calcification in the left anterior descending artery. So what the studies suggest, there is a study conducted by Manful sir et al., where they suggested that CTCA demonstrates the distal segments of the coronary artery aneurysms better, which cannot be or mostly missed in the 2D echocardiography. And in this study, it was suggested that when to do CTCA, they have suggested an algorithm. The children with Kawasaki disease at presentation, we should do a 2D echocardiography. If coronary artery abnormalities are absent, then CTCA is not required. If coronary artery abnormalities are present, then we have to go do a CTCA. Then we have to see whether it is distal aneurysms are present or not. If there is distal aneurysms, then we should consider CTCA on follow-up, because on follow-up also by 2D echocardiography we cannot assess the distal aneurysms. But if the distal coronary artery aneurysms are absent, then TTE or 2D echography may be sufficient for assessment of coronary artery dimensions. However, CTCA may still be required for the evaluation of mural changes, mural calcification, stenosis, and thrombosis. This is a recent paper in Lancet for the assessment of left circumflex artery, and here they have said that the CTCA is the preferred imaging modality for left circumflex in Kawasaki disease. And abnormalities in left circumflex are seen in 18.2% of children with Kawasaki disease on CTCA, and most of these, around 63%, were missed on 2D echocardiography. Now when we studied the different guidelines that has been published, the American Heart Association guidelines, the Japanese Society guidelines, and the Italian Society of Pediatric guidelines, the indication of coronary angiography in Kawasaki disease. So the indications is mainly from the I will come to the 2024 later. So it is the HA 2017 guidelines, which recommends the use of CTCA during follow-up when echocardiography becomes limiting because of the poor acoustic window as the child grows. And the Japanese Society has also suggested CTCA for the changes in the follow-up period, both Italian Society and Japanese Society. And in the acute phase in 2017, they said there was one line that CTCA can be of value in the assessment of selected patients but are not routinely indicated. And the same thing, the older children. And when to do CTCA, so almost both the guidelines, the Japanese Society and the American Heart Association is almost the same, that they are considering on follow-up. In Japanese Society guidelines, there is a first in the convalescent phase you should consider, then 1 year from onset, and every 3 to 5 years. Whereas in case of HA 2017, it is every 2 to 5 yearly, and the indication in follow-up is almost same, to look for the thrombosis, stenosis, and the mural abnormalities. And the calcium scoring that has been recommended in both the Japanese guidelines and the AHA 2017 guidelines. Now coming to the 2024 statement that has been published recently. So what are the changes? So the first line they have written that for the proximal aneurysms, both the CTCA and the echocardiography correlates well, but CTCA is superior for detecting distal aneurysms. And the study that they have quoted is the publication from Manful sir in the Oxford. And next is the long-term surveillance with CTCA is essential in patients with persistent aneurysms, particularly for detecting calcification, assessing stenosis, progression, and confirming thrombus formation. The new point that they have added, that during the acute phase, so CTCA is particularly useful at hospital discharge, so during the acute phase for giant aneurysms. And CTCA is helpful at 1 year from diagnosis. For the rest of the aneurysms, when they have proposed the CTCA should be done at 1 year from diagnosis as a baseline, and then every 2 to 5 yearly to monitor long-term complications. So to conclude, so what are the proposed indications? What are the indications for CTCA? So in the acute stage, for older children and adolescents where there is poor acoustic window, children with doubtful or equivocal echocardiography studies, children with a severe disease course in the acute stage like KD-SHOP syndrome, macrophage activation syndrome, symptomatic myocarditis, or any less than 6 months because they are aneurysm. Follow up to document the resolution of aneurysms, to monitor cannot be evaluated by echo, long-term surveillance of for abnormalities, and to delineation of stenosis and dystrophic calcification. Thank you.
The intima and others, it has not mentioned. So, thank you for discussing later.
एक्चुअली आपका ऑफिस 365 में
So please have already told us when it should be done. Now Dr. is going to tell us why it is to be done. So what is the indication why it should be done?
So basically role is reversed, but because I have to start with why CTC is required and then the indications Supreet has already told. So next 10 minutes I'll just be able, I'll try to convince you that why we are talking and